Good afternoon. I want to start by thanking T2 Biosystems and Werfen for the opportunity to be here today to talk about the impact of the T2 magnetic resonance technology on early detection of bacteremia and fungemia in critically ill patients. So we all know that bloodstream infections are a leading cause of morbidity and mortality in critically ill patients, and that early initiation of antimicrobial therapy is paramount for a good antimicrobial therapy. So the main problems with the current diagnostic tests for bloodstream infections is that although they are new tests that can provide a rapid identification and some resistant markers, they are still dependent on the growth from the blood culture bottle. So there is still a real need for new diagnostic tests that can be performed directly from the patient's sample. And that's exactly why the T2 diagnostic system is. So this is basically a benchtop device that you can see right there on the side of the boot. And that is a device that is based on the T2 magnetic resonance technology to diagnose bloodstream infection directly from the whole blood of the patient without the need for prior incubation or extraction process. So it basically runs in five different steps. The first one is the red blood cell lysis, followed by the concentration of microbial cells and cellular debris, then the cell lysis by a mechanical bead beating, a DNA amplification that is done with a thermostable enzyme and target-specific primers, and the final step is the detected amplified product by agglomeration of supermagnetic particles and the T2 magnetic resonance measurements. I want to hold on to this last point for just a couple of seconds to explain that in the beginning of the reaction, the particles are unclustered, as you can see here. But as the reaction goes on and as the primers bind to the specific targets, what happens is they get clustered, and that alters the magnetic resonance sign, and that it's picked up by the device. So, although T2 Biosystems has a pipeline with several different products that they will launch in the market pretty soon, today I would like to focus on three panels. The three panels are all CE marked, and those are the T2 Candida, the T2 Bacteria, and the T2 resistant panels. As you can see in this slide, data from the literature, all of the three panels have really high sensitivity and specificity with really good, extremely low limits of detection. There are much lower than the current standard, that is the blood culture. Another great advantage of the T2 Biosystems, the T2 device, is the turnaround time. Because as I previously said, when we use the blood culture or when you use the new diagnostic tests, you still need to wait for the growth in the blood culture. And with this device, you don't need to wait that long. So you can have a result from a species ID. And if you use the T2 resistant panel, you can have the result as well from some resistant markers in the space of 3 to 5 hours. And that's really good comparison with the other available technologies. At this point, I should probably say just one thing, is that you need to collect 1 tube of all blood for each test that you want to run. So if you want to run the T2 bacteria, T2 candida, and T2 resistance, you will need to collect 3 tubes from the patient, okay? So, at the moment, I would like to move on to the study that I am performing back home in my setting. It's a study of the impact of the T2 magnetic resonance technology on the detection of bacteremia and fungemia in critically ill patients. And I had the huge privilege to have a multidisciplinary team to help me with this process. It's a team composed by colleagues from the clinical microbiology, the intensive care unit, and the clinical hematology. So it's a really good team, and I'm really proud to be working with them. Just for those who don't know me, I come from Porto in Portugal, and there you have the picture of my beautiful hospital that is located in the city center. We performed a single-center prospective cohort study, and we were aiming for a population of around 200 patients. Some inclusion criteria. We performed these tests in adult patients with sepsis or septic shock, but then we used specific risk factors from each of the panels. For the T2 bacteria, we used predefined risk factors from patients who could have been in risk of bacteremia due to MDR pathogens, namely nosocomial infection coming from intra-abdominal source, genital urinary source, or fever without a known origin. Patients who were immunosuppressed, and then patients who had medical devices like, for example, for dialysis, prosthetic or vascular valves, lines, or etc. The last one was broad-spectrum antimicrobial therapy in the past 90 days for at least 7 days. Regarding T2 Candida, of course, the most important risk factor is neutropenia, but we also included patients that were not neutropenic if they met at least 3 of the risk factors that you can see there. Exclusion criteria: expected ICU stay length less than 2 days, palliative care intention, imminent on inevitable death, or prior inclusion, because we only included the first sample from each patient. The workflow was pretty straightforward, so we collected the blood in EDTA tubes and blood culture vials. They were transferred to the micro lab. We loaded the blood cultures into the automatic incubator and then did our routine standard. And in parallel, we performed the T2 bacteria or the T2 Candida panel testing. Before I move on to the results, I just wanted to say that for the data analysis, we used the classification of bloodstream infections that was previously published in the literature, and basically it divides bloodstream infections in 3 categories. The first one is proven bloodstream infection, where you have the T2 positive and the blood culture positive as well. The probable bloodstream infection, when you have the T2 positive and the blood culture negative, but the result of the T2 is also in another blood culture that was not paired for the study, a previous one or a further one a few days in time. And if there is a clinical sample from another site that also has the same pathogen. And finally, the possible bloodstream infection, where you have the T2 positive and the blood culture negative, but the clinical picture looks like a bloodstream infection. So, regarding the results for the T2 bacteria, what do we have so far? We performed 141 tests from a population with a mean age of 62 years old, and the results were quite impressive. So we have a median time to positive result and to species ID of 6.1 hours. If you remember, I said that the results will probably be done in 3 to 5 hours. But the thing is, this number is a little bit higher because the samples were batched. And if the device is fully running, it will take a little bit longer to get the results. But it's still quite impressive to compare with the conventional method. And if you look at the difference, it's a 36.5-hour difference between T2 bacteria and the current blood culture methods. Regarding microbiological results, we had almost every pathogen on the T2 bacteria picked up by the device. The only one we didn't have was Acinetobacter, but the other ones we had cases with them. But for the purpose of the data analysis, we excluded off-species panel. So after excluding those, there were 12 results. We came up with these results. So we have 27 cases of T2 bacteria positive and blood culture positive, 15 with T2 bacteria positive and blood culture negative, 86 with T2 bacteria negative and blood culture negative, and just 1 case where the T2 bacteria could not pick up the pathogen. So I just wanted to express the results in a different way. You can see here that the T2 bacteria caught almost every single pathogen that was present on the samples from the patients. So if you calculate the sensitivity and specificity looking at these numbers, we will have a percentage of sensitivity and specificity that is above 97%, and this is quite huge when we are talking about bloodstream infections. Now, talking about the T2 Candida panel. We did exactly the same as we did from the bacteria panel, but we have a lower number of patients because it's difficult to have a patient with suspicion of candidemia, at least at my setting. But we performed the test in 34 patients with a mean age of 65 years old. And yet again, the results were quite impressive. I think what strikes me the most here is that you can have a result of yeast in the blood in the same day, and that has a huge impact on the addition of antifungal therapy, because not every patient gets it from the beginning. So comparing the results from the T2 magnetic resonance with the blood culture, it's a huge difference, and you can see it's almost 65 hours of difference to get to the diagnosis. And those of you who work in intensive care, you know that this is really important for the patient. Microbiological results, we had the full panel expressed by the T2 candida. The blood culture only picked 2 cases, and we did not have to exclude any patients because the candida that were picked were all from the panel, and we have 2 with concordant results from the T2 candida and the blood culture, 3 with T2 candida positive, blood culture negative, 29 with T2 candida negative and blood culture negative, and none of them were blood culture positive and T2 candida negative. So as you can see here, T2 candida picked every single one of the agents that the blood culture picked, but it also could pick some cases that would be probably missed by the blood culture, and these are here. They are the patients that came from another cultures. So looking at the results and calculating sensitivity and specificity, we have a sensitivity and a specificity of 100% in this population of the study. So we have some results that are still pending at the moment, and those are from the clinical part. So these are coming soon. And I would like to finish with just a couple of take-home messages. The first one is that the T2 magnetic resonance technology seems to be an excellent diagnostic tool for early detection of Fungemia and Bacteremia in critically ill patients, that the reduced turnaround time of this technology may allow for the implementation of several antimicrobial stewardship strategies. The most important one, of course, is time to targeted antimicrobial therapy and appropriate antimicrobial therapy. However, there are still some concerns, and of course one of them is the inability to rule out infection due to the presence of off-panel species. For example, in my setting, Enterobacter cloacae is a huge pathogen in the ICU, and it's not currently covered by the T2 bacteria panel, but that could be one of the ways of improving the panel in the future. And the final thing is that current pricing of the test imposes the need to focus on selecting which patient would benefit the most of this new technology. And thank you so much.